would join, and they would need to recognize that we respect time. And I know that you're coming out of your very busy schedule, so I would not want to cause a bit of a delay for you and for those who have actually come very early. And so it will just be basically to see if I can go into straight the presentation, and obviously we're going to share the slides around for those who will want to be able to go through the details of everything they would have missed, although it would have been interesting to have them right here online. All right, I'm going to just open the presentation, and we will be on our way to go on starting. Brilliant. Anyone confirming to me they can see the slide? Can you see? Very good. Thank you very much. Right. So I'm going to be moving this stuff somewhere, and we're looking at the current management of hepatitis B infection. This is going to be just about 20 minutes or so of presentation. It might get boring at some time, but I think that it's just about the concept of disease. Disease is never exciting. And so if you get to be bored, just go for a cup of coffee and come join us. Now we're looking at the management of hepatitis B infection as it applies internationally. In other words, we're not looking at only a small section or category of people, but we're looking at what is applicable in the Western world as well as with outside of the developed countries. And so we'll go through some aspects and ending with treatment eligibility for acute hepatitis B infection. Now here again, we see an outline of what we're going to be looking at, defining small things, aspects, and then going into transmission and also prevention strategies. We will examine some symptoms and signs, delving into the diagnosis and how we can make a diagnosis of that, and a bit of treatment of acute hepatitis B. Hepatitis B is a virus. For those who may be joining us and who do not have basic clinical knowledge, it's a virus, a tiny germ, smaller than a bacterium, can be seen only by an electron microscope. That genetic material is characterized to have a double-stranded DNA. DNA, of course, is the segment of the cell that is actually like life wire that represents life. Hepatitis B virus belongs to the family known as Hepatnaviridae. This is just for the benefit of medical students and scientists among us. Approximately 2 billion people worldwide, that's about 7 billion people now, but 2 billion worldwide have evidence of past or present infection with hepatitis B virus. That is about 1 out of every 4th person in the world has been exposed. And so this is not a very genial disease. 300 million persons are chronically infected, of whom there are about 500,000 that die per year. Like, think about that. 2 out of every 1,000 hepatitis B viral patients will die every year. Now, you might think that 1,000, 2 out of it is just like a drop in a bucket, but that 2 could be you. And that means that if you are among the 2%, then obviously you are 100%. You don't want to be that 100%. So really think about that. The overall global prevalence is about 3.5%, showing very low rates in developed Western world and high rates of up to 10% in some regions of Africa and Asia. In Nigeria, where I grew up as a young child, some rates have been characterized to be 2 out of 10 persons. That's 20%. That's 1 out of every 5th person. And deaths from hepatitis B viral infection is usually due to cirrhosis or liver cancer. Obviously, we call that hepatocellular carcinoma. Now, for those of you who like maps, you can see so much of what's happening in Africa, sub-Saharan Africa, and most of Asia. Now, that is the region of highest problems. Now, looking at how we go about making a diagnosis for hepatitis B, you can go through many laboratory techniques, and so many of them may be confusing, but I would break it down in small amounts so that we can understand how we go about making a diagnosis of hepatitis B. There are two types of infection, acute and chronic. Now, when you hear the word acute, some people just get afraid and are overly excited. What does acute mean? It means, oh, that's terrible. Now, and then chronic again, oh, chronic. Some people misinterpret that to be severity. Now, think about it. Do you have an idea what that means? Is acute meaning something terrible? Does chronic mean to you severity? Now, we will look at the definition of what that means. It's all about duration, okay? Acute hepatitis B is when the infection lasts within a 6-month period, whereas chronic hepatitis B infection is defined as persistence of hepatitis B surface antigen, which is a diagnostic marker, lasting beyond 6 months. So in practice, if somebody comes to you with a positive test and you don't have evidence that they have had any infection, such as symptoms to represent that, you repeat the test 6 months thereafter, and when there is a presence of hepatitis B surface antigen at the 6 month test, then you can define them to be chronic. Now, for those who may have actually evidence and laboratory facilities to identify additional markers, they can almost make that diagnosis with this first blood test. Okay, let's go on then. So during an acute infection, there are 3 phases of manifestation. Majority of people will have what is known as subclinical disease, meaning that they have anicteric. Icterus means yellow eyes, jaundice or yellow skin. And so a lot of people will have anicteric hepatitis. The second group will have icteric hepatitis. In some cases, there are those who have fulminant inflammation of the liver. Now, fulminant means it rapidly damages the liver, and a lot of these will die. Don't be afraid. This is just about one out of 200 persons in the acute phase. But majority of those who have acute infection will actually clear the virus from their systems. That is, and a big that is the conditional matter there. If they acquire this infection as adults, if they acquired it as children, then the problem is that they will likely progress to chronicity. Now, chronic hepatitis B manifests by asymptomatic carrier state to chronic hepatitis. Asymptomatic carrier, I'm distinguishing it here slightly with caution so that it doesn't confuse you. The carrier state or non-carrier status is still chronic hepatitis. But when we say chronic hepatitis, people think about an ongoing activity, that is inflammation. And so it should be recognized that if somebody comes with a positive test that you think is chronic, they have 4 possibilities. Either they are chronic carrier status, meaning that there is nothing ongoing in their liver, or they are chronic active inflammation, meaning that there is some activity, some damages are ongoing within the liver. The third one is cirrhosis, meaning that the liver has become so fibrotic, as in the second picture you can see here, and it is not functioning well. Now, the fourth one, which is the most sinister and one that we don't want to happen to anyone, is when a cancer develops. And we know that hepatitis B viral infection is the most notorious cancer-causing mechanism of the liver. Now, although the predominant organ of damage is the liver, the disease can present with symptoms that are not directly due to the liver inflammation. That is, you have got something known as extrahepatic manifestations. The extrahepatic ones can occur in both acute and chronic infection. So in acute infection, somebody may have some rashes on the skin that may just be so confusing, or flu-like presentation. And chronic infection, they may have joint pains and tenderness and so on. The predominant mode of transmission of hepatitis B varies with the location of a patient. In regions, if you remember the map that I showed you earlier, with a high rate of hepatitis B viral infection, the most common mode of transmission is mother to child. In other words, in pregnancy, whilst the sexual and intravenous routes are the most documented in low prevalence countries. Now, let me put a point here. I remember that in Gambia and some regions of West Africa, the horizontal route has been described as most predominant. And I think that is the case because most of children in families play with each other, and those are toddlers. And that is how they would have cut themselves, and some blood will spill over, and then they transmit the infection among themselves. But I think that the maternal fetal transmission is predominant because the reason why that may not be top on the list is that it has not been well studied. And so this calls for lots of pediatricians who, and also obstetricians to actually do some studies that will demonstrate how the relative prevalence of this condition within that population. Now we'll go on to this point, which is looking at the risk of a mother. The risk approaches 90% in children of those hepatitis B surface antigen positive mothers who do not receive the immunoglobulin and hepatitis B vaccine at birth. That is the most important risk for people getting infection. And now the transmission can occur while the baby is in the womb, or at birth, or after delivery. And so the second part is that it is thought to be rare, that is, in the population of, sorry, let me just clear that, the paternal transmission. Of course, there was a question which many people are worried about. Can a father who is positive ever give this disease to a child? Now, the answer will surprise you, because some people actually think that this is not the case. But it has been shown from data from Taiwan that infected fathers of children born to hepatitis B negative mothers have had hepatitis B viral infection. The mechanism, of course, very difficult to elucidate. However, we think that there is close contact of unprotected infants with the infected blood or body fluids of their fathers. For example, a father drops a toothbrush and the child picks it up, rubbing their gums. Of course, who is infected will transmit that infection to a baby. And so that's one possibility. Use of razor blades and so on can be another mechanism, possibility. Transfusion of infected blood. Now, this is a bit low in countries that have actually enforced pre-transfusion screening of blood. This has become mandatory from 1986. So if a country has not implemented that, then the transmission of hepatitis B by blood transfusion is still predominant. Sexual route of transmission. Now, this is very interesting. I must say this because it has caused a lot of disharmony for many who were not clear as at the time that they had their diagnosis. Partners who were negative started accusing their partners, their other colleagues, thinking that they were actually exposed because of not being faithful. And so they have actually accused their partners, and are very sad, and it's caused a lot of marital disharmony. But this is possible mostly in the Western developed countries. But in the developing countries, the most common routes of transmission is actually in childhood. And so look at that with caution. If anyone comes positive, it is less likely that they have been in some kind of relationship. Okay. However, with a caveat, it is likely that there are some sexual routes of transmission ongoing, and so that doesn't rule it out completely. Percutaneous inoculation, that is when the skin is broken and or intravenous drug use, acupuncture, tattooing, and body piercing. Look at that picture. It's a very common thing. This generation of people this is missing a bit, but we do know that it was a culture in the existence of all to have tattoos and certain marks on the body for representation of cultural belonging. And that was an issue at that time. So look at that with caution. That is one of the causes Obviously, in our days, there are lots of tattoos ongoing, but if done in an unsterile environment, then transmission of this virus is real. Nosocomial in-hospital transmission refers to transmission of hepatitis B within the healthcare setting. Contaminated instruments or an accidental needle exposure or injuries are an important mechanism of this. When an organ from hepatitis B positive individual is transplanted, or from a patient with isolated hepatitis B co-antibody patient, now don't be worried about these terminologies, but recognize them. The recipient will then become infected. And so transplantation is not a very common thing in developing countries, but we do know in developed countries this occurs. And so as a rule, a lot of those who are going to be donors of organs will be screened. An endpoint, which I think may be important, is the occurrence of hepatitis B transmission when household articles are not well kept in a manner that will actually safeguard negative persons or those who are vulnerable. In other words, if somebody is not vaccinated and they use things like toothbrushes or razor blades or toys, which can exist indeed outside the body for 7 days, hepatitis B can be transmitted through that mechanism. So it's a very important point that should be noted by many who do not know this yet. How do we prevent? Pre-exposure vaccination, post-exposure vaccination, and special situations are relevant here. So the universal vaccination has come to stay. About 3 vaccine schedules are given, the most important being the birth dose hepatitis B vaccine, and subsequently 2 more doses. Now, those that are not immune to hepatitis B and are high risk of exposure or a poor disease outcome are most important to be vaccinated with this. So important, this is important. It is not every adult of the teeming population of developing countries who are negative that will qualify for this. It is very expensive endeavor, and so most epidemiological units have identified those who are at highest risk and who will then need to be vaccinated. For example, we can go to those who are qualified and who will need to be vaccinated. For example, people who are living in hepatitis B endemic regions of the world. Now, I said that already, practically difficult point, but we can tease it out. Healthcare personnel, there's no choice. In highly endemic regions are at risk, either to themselves or to the fellows and to the patients as well. And so they need to be vaccinated if they are negative or susceptible. In injection drug users, this is not so much a problem in developing countries, although we do know that those who inject drugs in developing countries hide their identity. But over in developed countries, there are needle sharing programs that can help them from transmitting these infections. Fourth point is that household contacts of hepatitis B surface antigen positive patients. I am not by any means saying that eating together will transmit hepatitis B infection. However, the contacts can be quite tight, and living in overcrowded conditions will actually expose people to products, blood, semen, and so many other products within that can actually transmit this infection. So that is a practical trouble, poverty-driven, and so on, and that can actually be an issue here. So people in that situation with a positive person in their family will need to be vaccinated. Men who have sex with men, there's no doubt about that. That's very high risk and has been recognized to be even a poor prognosis of progression of hepatitis B. HIV-infected persons will need that also because they are also at very serious risk. And then hepatitis B C patients will also require that mechanism. Now, for those who are exposed, how do we go about, preventing the problem for them? So examples of these include needle stick injuries. Okay, if you're working in a hospital and then you have a needle stick injury, or there is a kind of a splash of blood from an infected person onto your face or your eyes or some surface of yours that maybe have a broken continuity on the skin, then there is need for some vaccination to be able to prevent. Of course, some ideas about immunoglobulin use as well as vaccination to be given at the same time has been advocated. So think about that situation. There are special situations here. I'm going to dwell a little bit about prevention of mother-to-child transmission. Bear with me again. I remember telling you that this might get a bit tough, but we are just about towards the end of this presentation. And I remind you again, you're going to be receiving the slides, and so you will be able to go through this. But I will stress some few points on the special situations I said I was going to speak about prevention of mother-to-child transmission. One of my colleagues had sent me a message before this presentation to explain that this matter has become very important, and a lot of patients who are coming at their first antenatal booking have high rates of hepatitis B surface antigen infection. And so this is an important thing that needs to be targeted, because if we can nip at the bud or ensure that children who are born to these mothers have adequate control of their disease, then it's very likely that we're going to be seeing less cases of hepatitis B surface antigen and succeed in eliminating this disease in 2030. So we reduce sexual transmission, healthcare pass providers, and then so on. Right, so what is the mechanism here? What do we do for prevention of mother-to-child transmission? Now, it's a very Herculean one, but I will explain circumstances in the understanding of resources available to us. So babies born to mothers who are hepatitis B surface antigen positive should receive active and passive immunization. I would save you the headache of defining what is active and passive. But suffice to say, active immunization means giving a hepatitis B vaccine, okay? Whereas passive immunization to give immunoglobulin of hepatitis B. This should be done within the first few hours of birth. However, hepatitis B immunoglobulin is expensive and not routinely available in developing countries. Okay, I found somebody sending me a message that the doctor prescribed it and they were so confused, exasperated, actually looking for how they can acquire it. I explained, look, the WHO has done some research and they have recommended that in that situation, the hepatitis B vaccine alone can actually reduce transmission of hepatitis B in children born in that circumstance. So please do not exasperate yourself and kill or hit your break the bank because you want to make sure you get immunoglobulin to your child. Okay. In addition to above strategies, a mother who has a positive E antigen status, okay, or whose viral load is above 200,000 units, should receive tenofovir, that's one of the antiviral agents, from 28 weeks of pregnancy till after delivery. That can reduce the chance of transmitting the hepatitis B virus to the baby, okay? So that is much about that. We'll handle that again probably when we deal with chronic hepatitis B, but not today. How do we reduce sexual transmission? Use of condom when having intercourse with hepatitis B surface antigen positive individual. Again, this is with a caveat because married couples would have trouble with this. But I would say that if a married couple who is positive is on treatment, there is a definite mechanism that this virus is low and transmission of the virus is very minimal. And so they can cohabit and have children, okay? Ensure screening of partner and vaccination if they are negative. Of course, if there's vaccinated partner, then you don't need the barrier method, okay? Check hepatitis B surface antigen 1 to 2 months thereafter to ensure they have acquired the antibodies. For healthcare providers, how do we prevent transmission? Screen and vaccinate healthcare workers. In other words, I am one of the advocates that in highly endemic regions of the world, every healthcare provider who is being employed should undergo screening for hepatitis B. It is not unusual to have nurses or doctors die from liver cancer who were employed and have been working in hospitals and never knew they were positive to hepatitis B until at the point when they would have developed complications like cirrhosis or decompensated liver cirrhosis. And so please This should be something that should be taken up by governments and to think very seriously in highly endemic regions. So if you are found to be negative, then vaccination is important to protect you. Okay. Hepatitis B surface and hepatitis B viral positive individuals who perform exposure-prone procedures should also have regular hepatitis B DNA. This is important because if your viral load is above a threshold, then you should not do those procedures and wait till they fall. Okay. There are needle sharing programs available in developed countries. For transplant patients, there's a special mechanism there as well. I will spare you that one. Now, what do we do in terms of clinical manifestations? Again, 5 minutes to go. Don't go, stay there a bit. The manifestations, it will be handled in this session for hepatitis, for acute. We'll look at the chronic hepatitis later. Now, about 70% of patients with acute hepatitis B viral infection do not present with typical jaundice. Okay, remember I mentioned 3 things there: anicteric, icteric, and of course the other bit. Right. So 1 in 200 patients with acute hepatitis B present with fulminant failure and may not survive. Okay. And the risk factors for fulminant liver failure in acute hepatitis B are poorly understood, but we know there are a few things here. If you are using drugs intravenously, excess alcohol consumption or drug use, and you've lost weight in the 6 months before hepatitis B infection, you are more likely to have fulminant failure of liver. So in other words, if you avoid this and live a healthy lifestyle and you acquire this infection, you're more likely to clear the virus from your system. What are the basic common symptoms? Jaundice, yellow eyes, okay, or yellow skin. That, again, we mentioned that it's not in every patient. Nausea, which is feeling sick or being sick and feeling very tired and extremely nauseated, okay? The jaundice will appear about 1 to 3 months, and some people will remain very tired for months thereafter. I have a client who actually had almost a year of being very fatigued, but getting better now, despite clearing the virus. Okay, again, just buttressing the points of the symptoms. Temperature is not very common. For abdominal pain, and is also an important factor that should be considered, because in many instances, patients who develop pain that is so severe, much more than can be understood, should undergo additional investigations. What are the outcomes of hepatitis B acute infection? 90%, if they're acquired in childhood, in adulthood, will actually go on, in childhood rather, yes, they will go on to develop chronic infection. Whereas about 20 to 50% of those who acquire it a bit, 20 to 50% of those who acquire the infection between 1 to 5 years will develop the chronic infection, whereas adults, it's just about 5%. So please bear with me. This slide, you will understand it easier, but childhood infection, chronicity, adult infection, less likely going to chronicity. How do we treat acute infection? Mainly supportive, nothing to do. Not everyone who has acute hepatitis B will need to be treated. In fact, majority will never need to be treated, okay? It is when they have fulminant hepatic failure that you want to do something about that, in which case you can try tenofovir, but that is not usual. Hospital management is based on those who have some abnormal dysfunction of the liver. They are deeply jaundiced and encephalopathic. If they're elderly, age at first presentation, then you may want to admit them because you want to take care of giving them food, and if they have poor social support systems in place. Again, I've mentioned this point, buttressing the fact that antiviral therapy is not indicated except in a few cases of fulminant failure. But this is just because you want to prevent resistance or kind of development of another hepatitis B in a patient who may undergo transplantation for their infected or fulminant liver. So here, the summary, we have learned a few points. Hepatitis B viral infection that can cause acute or chronic diseases, and acute infection less than 6 months, chronic infection lasting beyond 6 months. Second point, transmission of hepatitis B in developing countries is most often horizontal, whilst via sexual routes in the West. Fourth point, acute hepatitis B presents more dramatically than chronic hepatitis B. And the last point is that hepatitis B treatment is supportive and rarely needs antiviral agents. Okay? I think you've done very well to stay with me till the end of this presentation. I would recommend that you book and look forward to next week's slot, which is actually going to look at chronic hepatitis B infection for many who would want to understand how we make decisions about treatment and how we monitor those who will need to be treated. This is where I will stop at the moment. I've got a few moments for questions from majority, a lot of you who are participating in this meeting. You can unmute yourself if you want to ask one or two things, and we just have about, just about a few minutes left.
Thank you very much, Dr. Onizim. I would like to congratulate you for a wonderful job and making what appears to be a complex subject rather very simple. Your presentation was quite lucid, and I'm sure we've learned quite a lot from you. I look forward to the discussion on hepatitis B viral infection, which often gives a lot of problems in developing countries. I'm aware of a number of people in our practice that raise alarm once we go to do a blood donation and have hepatitis B viral infection. I often have difficulty getting them to understand that they need to be thoroughly evaluated and they may not necessarily require treatment. The outlook in your place of practice in the UK may not be the same as what we see here in the developing countries. I'm happy to emphasize that the treatment for acute hepatitis B viral infection is mainly supportive and does not require the use of antivirals. I think that emphasis is very important. And in parts of the world, the developing countries, where there is a high tendency to use antivirals, particularly lamivudine, one of the most abused antivirals, this emphasis comes quite handy. So I'd like to congratulate you for this wonderful initiative.
Thank you very much for your summary. That was quite professorial, and I appreciate that from Professor Uloko in Aminu Kano University Teaching Hospital. That's brilliant. It's a capsule summary that just buttresses the point, because many times patients become sick and then the first thing people think about is drugs. And that's the least thing you want to do for somebody with acute hepatitis B. Thank you very much for that comment.
Thank you.
Yes. Any further questions? We've got just about 5 minutes left.
Hello.
There's a bit of, okay, very good. So if you're not speaking, just mute yourself so that we can hear those who would speak. Who is speaking? Just indicate so we know.
He's Nantok, that way.
Oh, brilliant, Nantok. Go ahead, please.
Okay, sir, you spoke about the management. You said someone with hepatitis B will only need treatment when he has fulminant hepatic failure. So, does that mean the viral count and all those other criteria doesn't count again? Has it changed?
Very good question, Nantok. So for somebody who's fulminant failure, the passion at that point is to keep them alive. So there will be a lot of coagulopathy. So you will want to be able to make sure that their liver function is supported And so you would vitamin K, making sure that their clotting time is controlled. And for them, there are cases that can be made. And the reason why you're giving them tenofovir or antiviral agents, as the case may be, is intended to prevent the recurrence of the hepatitis when they actually will need transplantation. Because the aim of treating them, keeping them alive, is that if the liver fails eventually, they will be transplanted. And when they're transplanted, if you don't give them antiviral agents, they are more likely to have a recurrence. And so that would be the aim at that point. So if you're living in a facility that actually the basic idea to transplant is not even there, so the most important activity to do is to actually make sure that they are well supported so that the liver does not fail further. So yes, you could make a case to giving them antiviral agents, but that is a secondary matter, just to make sure that they are well supported. But the majority of patients with acute hepatitis B infection do not need any antiviral agent treatment. They will clear it from their systems without any treatment, just supportive care.